on Aging. And I'm your host, Elena Volpe, and I'm so happy that we're back here in person for this winter series after 2 long years on Zoom. But we do have a Zoom option for those of you who could not be present physically here. You're going to be missing the wine and cheese session afterwards. So think about it next time. So the Silly Center on Aging that I direct sponsors this series of 5 lectures, which start on the last Tuesday of January, which is today, and go on for 5 weeks until the end of February. So it features nationally and internationally renowned speakers, including some of our own, who are going to come in the next few weeks. Who focus on topics relevant to aging and geriatrics. This lecture series honors the memory of Dr. Edward James Lefeber, and starting this year, it honors also the memory of Dr. Nancy Lefeber Hughes, who was his daughter, Edward Lefeber's daughter, and died prematurely last year because she was killed by a hit and run in a run accident while she was riding her bike. So both Dr. Edward Lefeber and Dr. Nancy Hughes provided medical care for the citizens of Galveston Island. Dr. Edward Lefeber started in 1939. He also taught internal medicine at UTMB. Over time, he became interested in geriatrics because he saw that many of his colleagues were not comfortable taking care of older people, and so he preferentially started to take older patients. He became the director of the Turners and Moody's House, which now is the Meridian Retirement Community. And before he died in I believe it was 1988, UTMB started to develop the division of geriatrics. After his death, family and friends brought together this endowment and in his memory in the City Center on Aging. Dr. Nancy Lefeber Hughes started her career in healthcare as a nurse. And then, after about 10 years of work as a nurse, she went back to medical school here at UTMB, where she graduated in 1994. And then she did a residency in internal medicine and then became a faculty in general medicine here at UTMB and worked here for several years. After Hurricane Ike, Dr. Hughes opened her own private practice, and which she kept until her death, unfortunately. She took care of more than 2,000 Galvestonians, and she was an excellent and compassionate doctor who gave her patients her undivided attention, and she loved to attend the winter series on aging, and we all miss her. So today, we're really very, very fortunate to host Dr. Michael Wolf. He is the James Webster Professor in the Departments of Medicine, Medical Social Sciences, Psychiatry and Behavioral Sciences, Surgery and Learning Sciences at Northwestern University. He is the director of the Center for Applied Health Research on Aging and the brand new Claude Pepper Older Americans Independence Center at Northwestern University. Dr. Wolf earned his bachelor's degree in psychology and English from Valparaiso University, and then he got 3 master's degrees, one in social work from Loyola University, one in public health and epidemiology and statistics from the University from Northwestern, and the other one in learning sciences, also from Northwestern. Plus, he got his PhD in social policy from the University of Illinois. After a postdoctoral fellowship, he became a faculty at Northwestern University, where he's climbed up all the academic ladder and is now in the position that is holding at this time. So his research is funded by many NIH grants, including the Pepper Center, and focuses on cognitive aging and primary care management of multiple chronic conditions in older adults. He's mentored many students, postdoctoral fellows, and junior faculty, and has participated in many prestigious national and international panels and received many honors and awards, including the National Patient Safety Foundation Health Literacy in Advancing Patient Safety Award and the Fulbright Distinguished Faculty Research Scholar Award. And so today his talk is titled Optimizing Primary Care for Older Adults with Multiple Chronic Conditions, work of the Northwestern, Pepper Center. And so please join me to welcome Dr. Michael Wolf. Sorry.
I know, definitely Northwestern. I usually get confused for Northeastern and Boston, so thank you for at least not throwing those two directions out. I really am excited to be here today, and I really greatly appreciate the invitation to come here from Dr. Volpe. We've only been a Pepper Center at Northwestern for going on our third year now, and Elena was one of the first to be able to extend an some wonderful words of wisdom, and as we've been trying to really start our journey and kind of work that you've already been doing for many, many more years. So thank you very much for letting us learn a little bit more from what you've been doing. And today I'm really going to be just wanting to make sure I know how to advance the slides. I'm using the arrows, but unless they want me to do a clicker. Is it going through?
It should be good.
Maybe it's just which direction do I point? Okay.
It was working earlier. I'm not sure.
Yeah. No worries. One moment. Sorry. Okay. Oh, I can use the keyboard.
This should work.
Oh, good. There we go. There we go. So today is really just going to give a little bit of a highlight of the type of work that we're doing, because it is a bit different than many of the other established Pepper Centers, and it reflects, I think, a very applied research agenda where we're trying to kind of think about what can we be doing now to really help improve how the healthcare system can best manage the increasing number of older adults that are going to be using all of our healthcare services now, and actually be proactive about it. So a lot of it reflects kind of I want to say an informal research agenda, but what it really has become more established with our Pepper Center. And we thought this would be a great opportunity because there's so much that we can learn from other Pepper Centers that are doing things that are differently, and we're hoping that we can be a complement to the network that is really about focusing on how do you optimize function, independence, and quality of life as we all get older. Throwing this out here, this is what I left to come here, and I was really hoping for sunshine and t-shirts in warmer weather, but I did the little comparison and realized I'm still doing way better off by being here, and lingering a little bit longer wouldn't be bad. Although I think tomorrow's going to be a balmy 23 degrees when I land and have to find my winter coat that I left in my car. But yeah, so this is our Chicago. You can actually see probably close to the far right of the screen is getting close to where our offices are and our medical center, so you can see where our perspective is. My quick outline of what I'm going to just talk about today. Again, I'm just going to highlight our Pepper Center. Again, Northwestern has always had a large aging research agenda, but it's just now really coming to a formal kind of bringing together of a brick and mortar institute like you have here. And so that's why this was also a good fact-finding mission on how can we do things following your lead. Again, our emphasis is on health services research. So it's really looking at how we improve healthcare delivery and recognizing that a lot of primary care is set up to do really well for that 22-year-old that came in with a sinus infection and probably didn't need to come in. But maybe how do you deal with patients that require a little bit more complexity and better engagement, and recognizing that we don't always do a great job at that. And so the thought is really, what can we do to better tailor the services to those who most are likely to use the services? So that's what our emphasis is on, again, real world problems and kind of looking for optimal improvement. So I'm going to walk through a little bit of who we are and show some of the faces who are of our center and the work that's being done. showing some of the new resources and cores that we're hoping to kind of bring to the Pepper Center in terms of ways we deal with patient-reported outcomes measurement and really kind of bring together what we would call patient priorities aligned care, and really thinking about that as we age, we really should have a way to include our voices, our families' voices into the mix in the clinical decision making. Also going to introduce you to some of the work that's being done right now, and then also kind of some other new kind of developments that hopefully will make us a decent collaborator to UTMB, among others that you've already been working with for a while. So this is kind of just giving a flavor of the month of what's happening with Northwestern, and really trying to find ways, hopefully coming out of this meeting, to find ways that we can really kind of coordinate and collaborate. A little brief bio of me. So I do come from Michigan, so I'm used to the cold. Have been at Northwestern now for 23 years, and my focus has been on health services research, behavioral science, and cognitive science. So these are things that are somewhat new, and I think not as maybe a major focus of the work that we've been doing with the NIA through the Pepper Center, but we're hoping that we can bring all of this to kind of create some new ways to think about, again, how we deliver healthcare. Spent some time as Elena mentioned, I spent a year doing a faculty Fulbright, bringing my family out. That was a lot of fun, bringing kids, and at one point, watching them kind of adapt. We lived on Penny Lane, no joke, and I thought my comment to the driver who picked us up, I said, "You guys must be sick of the Beatles by now," and that was probably the worst thing I could have said to a Liverpudlian. And we collaborated and still collaborate a lot with and have some great relationships, working very much on aging research with University of Edinburgh, UCL, and University of Leeds, where we do a lot of work, and love to talk to any of you more about that as well if you're interested. For the Northwestern Pepper Center, again, for those, I'm assuming many of you may know of the great work that's already been done as a longstanding member with UTMB at the helm in the Pepper Center network nationally. Again, the focus really being on geroscience and really, again, trying to prolong function and independence and quality of life among older adults as we age. Our change was really the new emphasis that was allowed was to kind of really think of an applied approach. And so the NIA, the National Institute of Aging, started to allow more recently, centers that could focus on, let's think not just maybe more basic science and just understanding elements of aging, but also thinking about how we deliver care to all of us as we start throughout the life course process. And our focus really is, again, I'm based in general internal medicine, and so our focus is really on those on the front lines of care that are very resource constrained, don't always have care coordination services or a pharmacist or a social worker or a psychologist or other kind of ancillary healthcare services that maybe subspecialties may have. Our focus is on those that have financial constraints, time constraints, and try not to imagine that every patient, that comes in through primary care that may be diverse by age and comorbidity, that you can't take a cookie cutter approach, that you really do need to figure out a better way to kind of really utilize the time resources that you do have with the patients that you do want to understand, like how often you should follow up with the patient, how much time you should spend with a patient. These are the questions we've been asking ourselves. And the emphasis specifically around older adults with multiple chronic conditions, and I'll explain that in a moment, as many of you may know why. We are only also the second Pepper Center for the Midwest, so that was one of our calling cards is, hey, don't ignore us. We're not just a flyby region of the country. Pitt, I think we had to argue with, is not part of the Midwest, sorry for those of you from Pittsburgh. So we view ourselves the only two in the Midwest. We were funded, we got our score for our grant in February of 2020, which was great excitement, not knowing what was about to come. It's been drinking from a fire hose as we launched our NIA Center during a pandemic and being remote, as all of you know, and dealing with a lot of that. Just also our Center for Applied Health Research on Aging just got its endowment from the institution just months before. So it's all been a learning experience, but it's been great to finally get our feet under us a little bit. Our theme for our Pepper Center is really, again, a primary care management of older adults with MCC, really thinking that the problem that we face is that there will never be probably enough geriatricians to manage what we are about to see as an influx of The baby boomer generation now leading us to a very, very large over 65 patient population. So the trick really, according to Mary Tinetti at Yale, has been to think little g, not big G. That you need to figure out how do you take the workforce of primary care physicians and infuse geriatrics principles into their care. They can't be continually thinking about how to deliver services in a en masse kind of approach, but really understanding what geriatrics excellence kind of really offers in clinical care and training the workforce to address that. The focus on multiple chronic conditions is such because, compared to older adults with only one or no chronic conditions, we see worse clinical outcomes, poorer physical and mental health, greater risk of hospitalization and readmissions in particular, and that's been a major emphasis of Medicare in terms of how they're now auditing health systems based on 30-day readmissions, reduced quality of life, and again, increased mortality risk across all causes. So again, older adults with MCC, no surprise, represent 71% of US spending. Out-of-pocket costs are twice as much than those with one or no chronic conditions, and self-management is increasingly complex. A lot of what our lab does has been trying to deconstruct what it means to have care complexity. Not just so much from the standpoint of thinking about number of chronic conditions, polypharmacy, how many medications are you taking about, but really what are the self-care tasks that you have to manage on a daily basis, and what makes life complicated, and how can our healthcare system not really blame patients for non-adherence issues, but rather think about how do we actually try to optimize and reduce the burden of being a patient for everybody. And that means leveraging technology, that means more touch points with patients, that means better communication. It means that it takes a multifaceted approach to think about healthcare in just a different way. And a lot of that deconstruction for us is thinking about, again, what makes it difficult to be a patient when you have multiple chronic conditions. And from the patient perspective, obviously it's a lot. It's being told that you have to manage multiple lifestyle changes at once. It's thinking about the dynamic behavior of taking medication. So I've done a deep dive in my career on, from a patient's perspective, what does it mean to take prescribed medications? And it is probably, I would argue it is the most dynamic health behavior one has to take. If you think about multiple medications, regimens that make a daily change, or not necessarily a daily change, but whether it's the look of your medications because a switch in generics to having medications being replaced out, having guest appearance drugs like that might be PRN or Prorenata, just as needed medications coming into play, mixing in over-the-counter medications. It's a very complicated, unnecessarily so task that really does dominate a patient's life. In addition to that, you have the high prevalence of functional limitations that affect self-care ability and how well are they actually kind of acknowledged. And I'm not going to read all of these things, but in addition, whether it's financial costs that kind of come into play, a lot of these things are not really necessarily known by the clinician, but are basically experienced by patients and their care partners. So a lot of that is just trying to recognize that and appreciate that and thinking about what services could be deployed to kind of reduce that burden. But there's also challenges to primary care, which is why we take a specific focus on primary care providers and in thinking about what their lives and what resources they have or don't have that also add to the complexity of managing patients with, again, multimorbidity. And again, a lot of issues are really, especially in the aging component, is even thinking about evidence-based guidelines that focus on one, not multiple chronic conditions and how we actually deal with that. There's not just yourself in the mix, but you have subspecialists, and the communications from one provider to the next can be also broken. Lack of continuity of care is a huge issue that, there's multiple currently national initiatives trying to address that. And also issues around patients' involvement in treatment decision-making is becoming increasingly important as you get older, where decision-making might not be that there's one perfect choice. Treatment A may not necessarily be better than treatment B without factoring in some elements of a patient's preferences, because it does affect quality of life. So thinking about all these things together, there's a lot of reasons why we need to focus, at least we believe, on primary care among these individuals. Again, our research agenda is a pragmatic one. We're very much about thinking about how we can design new healthcare models, interventions that could be deployed tomorrow and be highly scalable, and thinking about that, not just something that might be an NIH study that we do, we get a few publications off, and ultimately nobody picks up because it really didn't make sense to begin with, or there was no cost channel to kind of sustain it over time. Our expertise, again, that we think that we're offering, many of which we think might be unique and at least hopefully make us a decent partner to UTMB and others, is really thinking an emphasis on cognitive and behavioral social sciences, communication science. Again, we do a lot of work on, again, patient-provider communication, and also not just the spoken communication, but how we actually engage new health technologies that patients are starting to learn how to use. We saw about a 170% increased uptake of patient portal usage in our health system. So all of a sudden, because we stopped communicating with you in person and we sent you to telehealth, and I don't know how you did at UTMB, but I think at Northwestern we were not prepared. We were not prepared to send patients for about 3.5 months fully remote and out of our healthcare system. And a lot of it was variable from one patient to the next, from one provider to the next, in terms of whether it was going to be a phone call, whether it was going to be a video conference, how we even onboarded you to the technologies and so forth. So we've learned the mess that we had, and now we're trying to figure out how we can actually do things better and actually even kind of engage and sustain telehealth to some degree. We have a lot of research in health informatics and data science, in thinking about how we understand patient experiences with new treatments, knowing that there is immense amount of real-world data and evidence available that's coming through, whether it be social media channels, through electronic health records, data sources. We're trying to harness that so we can actually detect signals of efficacy and effectiveness as well as potential harm. And so that is also a major agenda for the FDA and others, as we start to realize that once you have a drug's approved for one thing, it oftentimes does not get approved for a second indication, and yet we start to learn through clinical decision-making that it can be used. But a lot of our interest is also leveraging our health informatics teams to understand the benefits of some treatments and also detecting new harms that might not have been signaled when a drug was first approved. A major element for us, I'll mention later, is dissemination and implementation science, and thinking about not just taking stuff from a clinical trial that you found something to be effective, but then really understanding how it can kind of be embedded into a large healthcare system and sustained over time, and understanding how to assess fidelity and reliability of those interventions over time to make sure that these things actually can change to practice improvement and new standards of care. And a lot of our work, myself included, for the past 20 years has been really focused on clinical trials, but a very specific, I would say, a pragmatic trials that you're trying to launch into a very difficult and oftentimes turbulent healthcare system where you cannot control for all elements. It's not going to be a perfect experiment, so you have to kind of recognize that there's still benefit to doing I don't know if you want to call it quasi-experimental, or at least there's new kind of emphasis on pragmatic research where we just need to start doing something. A lot of our research actually fits into quality improvement, where we go in and take clinical practices and ask them to live with our intervention as a practice standard for a period of 2 to 3 years so we can actually observe it and see if it actually made change. So a lot of comparative effectiveness and research as well. Our center is situated within a division of general internal medicine, within a department of medicine, talk about Russian dolls, and an institute of public health and medicine. I'll mention in a moment, we do have a new longevity institute that the Pepper Center now situates itself in as a primary, one of the core 6 centers that gives us much more of an ability to look like other Pepper Centers in doing some of the wonderful basic science research that's going on, and we're looking to connect that as well. But we also, again, going back to that real world approach, we have long-standing partnerships with some of Chicago-based large-scale federally qualified health centers. So in our DNA, our goal is to take what we learn and may know works in academic setting and see if it can be replicated in community sites like federally qualified health centers that provide primary care to medically underserved populations. So we have two of the largest federally qualified health centers in the nation in Chicago, and so a lot of our work is actually including replication sites in these centers that we actually provide electronic health records research support for. We also work with industry. So Walgreens, for instance, is based in Chicago, and we actually have a master agreement with them. So we're finding right now we have a project working called TEAM, funded by the Gordon and Betty Moore Foundation in California. That's the money that came from Intel to figure out how you can actually embed community pharmacists with read-write capabilities with an electronic health record to provide care to patients across these clinics, doing everything from medication reconciliation to sharing of data around treatment adherence with fill data to actually doing comprehensive medication reviews and flagging adverse events. So that's been actually a nice partnership over the past 8 or 9 years. And another thing, despite what I showed you in the ice sheets in Chicago on Lake Michigan, I think there's a lot of value to hopefully including Chicago as a partner for you all. One, not only are we the largest Midwestern city, third in the largest in the US, but Chicago is an interesting place to do research. One, sadly, because it's a city that has suffered long and has never really fully recovered from segregation, where community areas from our first Mayor Daley really kind of chopped the neighborhoods up. So you do have very unique and homogeneous community areas throughout the city. Chicago is roughly a third non-Hispanic white, but a third Hispanic and also a third black. And you have rich community areas with these community health centers that we've been partnering with. So you get kind of a real easy way to study health disparities and address a lot of these DEI issues that have been kind of that have been a long time been over appreciated. And our health system is large. We are now up to 11 hospitals. 2 are physical medicine and rehabilitation hospitals, including the Shirley Ryan Ability Lab, as well as 200 plus ambulatory care practices that span urban, suburban, and yes, even rural locations. We're getting pretty close to the cornfields of Iowa as the last time we've kind of expanded. So you're talking about 6+ million lives that are actually covered by Northwestern. So again, one of the things we're trying to find is ways that we can actually, again, support some of these large pragmatic trials with health quality improvement studies that we can kind of by randomizing our practices. And I guess not a great way to kind of flag how great it is to include our state and our city as a Pepper Center is we also really don't do well with older adult care. So we one of the arguments for including the Pepper Center is we desperately need innovation in Chicago, in the Midwest, around improving the way we think about quality of care in terms of rankings, how we both, in thinking about effective transitions of care and quality of care for older adult populations, despite this Chicago having the second largest over 65 population in the United States. Just quick view of our leadership for our centers. We have, like all Pepper Centers, a research education component and a pilot exploratory studies core. Those are merged in our Pepper Center, so we basically prioritize junior investigators only to get pilot research funds to support the work that's going on at our research at our center. We have 3 expertise that we bring together that are based on Northwestern leadership nationally in terms of research around healthcare technology and design. We've got projects that are trying to find ways to leverage real-world technology like Amazon Alexas and Google Homes out of the box, not to be repurposed or reprogrammed, but what functionality do existing technologies that you could walk into a Target or a Walmart and basically with guidance purpose it to provide care, improving well-being for older adults. In this case, it could be medication reminders, playing music for homebound adults, to adding communications between care partners who may not live or reside with the patient so that they can kind of maintain connections, as well as finding ways to leverage the technology to also keep a tether to provide assessments of patient-reported outcomes and communicate that information back to a healthcare provider. And a lot of our focus is on human-computer interaction and also user-centered design of technology-enabled services for older adults. How do you make sure that these technologies can be utilized, whether it be a Fitbit, again, Amazon Alexa, an iPad. We have a group that does iPad boot camps. to really make sure people can actually understand all the functionality of these tools that can address everything from social isolation to cognitive gaming, among other tools. Northwestern also is the lead for the PROMIS, or Patient-Reported Outcomes Measurement Information Service. So PROMIS is led by David Sella, is kind of the data harmonization is the NIH preferred method for assessing patient-reported outcomes, whether it be physical, mental, emotional health, pain, fatigue. That's under the Health Assessment Lab. That's a very big piece for us that we're already starting to include into the National Pepper Network. And then also and that also has the NIH Toolbox. So we're also one of the primary sites that led the cognitive behavioral neurological function assessment. So a lot of the tools that the NIH wants us to use in research is what we've got hubs at Northwestern, so we're hoping that that will be another expertise to add. And then finally, we have a data analytics core that both prioritize not just quantitative innovations, especially those that try to factor in that most trials require multiple primary outcomes, not just one. And how do you factor that in from your power calculation to your analysis plan? So we've got a lot of our biostatisticians working on things called the win ratio and others to improve the way we think about clinical trials. But we also focus on qualitative analysis and mixed methods design, because a lot of our research needs to best capture in the most comprehensive way patient experiences. And a lot of that means we really need to kind of have conversations, not just surveys with patients, to capture and learn from our target populations. So other projects that we have going on is I think I mentioned already some of these issues around technology-enabled services. So we're actually coming up with a manual of operations on how best you design any type of, best you approach thinking of any kind of new technology from the perspective of aging and familiarity with technologies, to how to onboard these tools. We also, our measurement core is right now thinking, we have a platform called NM Pro at Northwestern. So as part of our clinical care, we do in context of orthopedic surgery, rheumatology, and oncology, we routinely collect patient-reported outcomes, and those are based on patient priorities. So we ask patients, what is the most important thing to you before you have your next scheduled visit? And for some people, it may be urinary function, it may be pain, it may be fatigue, it may be emotional health, and based on that, we want that to be able to at least kind of get up in the queue in terms of prioritizing what gets discussed in that very fragile period of time, that very narrow amount of time that you may have with patients. It also helps the care team prepare to know exactly what they might need to be able to have on discussion and thinking about referrals. Our analytics core right now is also thinking about issues on how big of a mess electronic health records are, and we like to talk about EHRs as if like the data is clean and available and comprehensive, when in fact it's not. And oftentimes we don't even know what a patient's true condition is. We don't even know if, do they have diabetes? I think they might have diabetes. When was that actually documented? They look like they're taking a medication for diabetes. So we're coming up with an algorithm right now that actually is about to go out for publication that really just tries to start looking in different contexts. Do we actually know if someone has the condition that we think they may have when you're actually looking across multiple providers, multiple data entries, and also not just discrete fields, but also a lot of the clinical notes. So we've been applying some machine learning processes, including natural language processing, to capture that as well. Just quick architecture that I don't need to spend a lot of time on. We do have an information dissemination course, so that's another thing that we've been trying to leverage, is how best to create information sharing opportunities, not only with other Pepper centers, but also with NIA and other organizations. So how do you kind of really address the research to practice gap? And this is something that we're thinking a lot about right now. Research stagnates. And a lot of times we do work that it takes a very, very long time. I believe it's 10 to 15 years in some cases for the culmination of findings in a trial to actually populate into a practice standard, to actually have meaningful change and to actually change tactics for a healthcare system that may be very, very slow to adopt. And so we're trying to optimize that at that moment with working with our Clinical Translational Sciences Institute. And again, the cores and the research education core and pilot cores I've already mentioned. Again, we focus our work on junior investigators. We're trying to actually help build the next generation of aging researchers. So they receive the equivalent of an RO3, which is $100,000 over 2 years, which is their budget. We fund about 5 to 7 of those awards per cycle, and they also get free analytics support that doesn't have to be budgeted into their project. And also they get a core mentor team to ensure their success as they get married through. We've given 17 awards to date. And actually, I would love feedback. Elena, we don't know what is a lot. I don't know what you're training a lot. I will say this is our first 2 cohorts. Yes, there is a common denominator about our first 2 cohorts in terms of who the best candidates were in terms of our submissions. We received 57 submissions for our first competition and 41, I believe, with our second competition. So we feel like we've unearthed a good amount of aging research that just was maybe kind of lying dormant. And so at least we hope that we're on the right target. But yes, we have an all-female first 2 cohorts that have really kind of launched very, very well, and we're very proud of. And again, off a lot of different specialties. In fact, I think we've 3 of our aging researchers are from OBGYN. That we had not expected, and so we're very excited that we've gotten everything from research that's really targeting older women's health as well. Our next cohort came through, also is starting to get a bit more dynamic in terms of research. Our topics really are, like everything from cellular senescence to looking at remote telehealth use for rural health and managing anxiety and distress among cancer patients that do not have immediate access to their healthcare system due to distance. Looking at cardiovascular risk prediction and prevention. Everything, and also I don't need to read all these things, but also issues around sleep. Other research we've got going on, a lot of it is cognitive aging focused, so we're looking at midlife and later life cognitive decline. And actually on the flip end of it, we have my focus on a lot of my research is looking at trajectories of cognitive decline and its impact on self-management of multiple chronic conditions, where our Alzheimer's Center actually has superagers research going on, looking at the people who are well preserved through, and what are the risk, or not the risk factors, excuse me, at all. What are the wonderful factors that actually predict superaging in later life? We have also in cardiology research tied to our center that's looking at super aging from a physical sense in rural Indiana among Amish patients, an Amish cohort that's been longstanding, led by Doug Vaughn. But again, a lot of diverse research that is, again, thinking beyond maybe physical indicators of health, but also patient-reported priorities, and also personality factors, cognitive factors as well that we're thinking in, that also looking at how patients age and how well they age. Some successes we've had, thanks to the Pepper Center award that we've received. It did lead to a new geriatrics division, which we haven't had in about 25 years. And that has led to multiple geriatrics faculty lines that have been opened up, and led by Lee Lindquist. We have a longevity institute that led to an endowment coming through that, again, is looking to expand the human health span. So this is actually a center that is, or an institute that is very geared about creating biobanking. They're trying to create a Northwestern set of both patient and staff cohorts where we're trying to actually collect a large amount of data as much as possible to well characterize and track over time an expansive data on both, again, us as guinea pigs, our employees, as well as our patients. Again, 6.2 million. And again, Northwestern was fortunate to be featured as one of the core 6 centers. We have an implementation science hub. So I don't know if that's also a major focus for us. Again, if we're trying to come up with what are best practices, then the next step is how do you get those best practices to be adopted by a healthcare system? How do you get the C-suite to accept the evidence that you're presenting them that this might be a better way? And again, it's like a slow turning ship, trying to get that evidence in a palatable manner and work that process through has kind of turned into this new field of a relatively new field of dissemination and implementation science. So we've been lucky to be able to pull from both University of Pennsylvania and also Brown University, two national leaders in implementation science research, and to thread them into our Pepper Center. So that's becoming a new theme probably for our next renewal proposal. And another big element that we've been focusing on is Pepper Center research registries. So that is something that we are pushing out right now. Again, I think it's 6.4 million, stand corrected, patients that are touched by the Northwestern healthcare system. Everybody is going to be receiving a invitation through MyChart, their patient portal, to be in the study. We're going to better characterize this cohort through multiple iterative surveys, and hopefully this will also kind of jumpstart the research that we're doing at Northwestern. And again, the secondary rollout will be with 2 federally qualified health centers that we're going to be trying to bring on board that also use Epic and include them, so we'll actually make sure that we have diversity in the enrollment and the capabilities of our ability to support new and future research studies. The other interesting thing that we've launched at Northwestern is NM Pro, and I mentioned it earlier. We have a dashboard that is patient-driven care planning via, again, routine collection of patient-reported outcomes. And so these are some snapshots in Epic that are right now available to clinicians in certain subspecialties. The hard nut to crack is primary care. How do you try to get patients in primary care, given how diverse the patient population is, to think about maybe sharing prior to a visit their self-report of how they're doing physically, mentally, again, thinking beyond just physical and mental health, but fatigue and pain and cognitive, their self-reported, and thinking about their subjective perspective on how their cognitive function is. And a lot of it is, again, how we're trying to probably target in specific patients, again, specific medical comorbidities, or even just thinking of older adults with multiple chronic conditions, or patients that have some demonstrated maybe need based on not meeting maybe clinical goals in terms of their health. And again, a lot of this also using flow sheets in Epic is thinking about how we can actually track not just normative decline, that based on the normative data of a particular test, we see that you are below normal now, and we need to, it's a clinical signal for us to reach out. But to start trending with flow sheets, now if we were doing this more routinely, you can actually start to look to see how patients are doing, even if they're doing above normal. And a great thing, we were doing that right now with funding through the National Institute for Neurological Disorders and Stroke, is doing relative decline of cognitive impairment, especially if you have a healthcare system that has patients diverse by educational attainment. That patients, especially if they're coming to you saying, I think something's not right, my memory is failing, I'm having more difficulties on a daily basis, but they test out normal. But you can start tracking over time and say, well, maybe you're on a trajectory and we can do some early intervention, or at least think about things earlier than almost in a pre-MCI state. So that's something that we've been doing right now, and it's underway. And finally, again, to that point, that project is what's called Detect CID. So we are one of the 3 centers that is funded by NINDS to do large-scale clinical trials. So we spent the past 5 years working as a consortium to develop ways to mobilize primary care to better detect cognitive impairments and dementia. And through that was developing better tests as well as turnkey recommendations to know what to do if you do identify a patient. Besides just maybe creating anxiety among an individual because now they have to wait 6 months for a behavioral neurology referral because of the backlog, and we just don't have the bandwidth for it. So a lot of it is trying to think about, if you actually do believe the Alzheimer's Association that if you detect things earlier, you will actually improve care planning opportunities, maintaining independence and function for an individual, and in just overall might have a better chance at quality of life. That's where we're really trying to kind of focus in on. And so now we have been refunded for 5 more years to actually do a clinical trial of the paradigm that we've spent the past 5 years building. And that also includes UC San Francisco, a Pepper Center member, and also Einstein in New York. So kind of in closing, I kind of throw out opportunities to collaborate. We're a little bit of a different Pepper Center. I told Elena earlier, one of our colleagues referred to us as, wow, you're unique, and being unique may be nice, but it's also feeling like an anomaly. Sometimes you also want to kind of have some similarities to the group. So we hope that we have some novel contributions, and would love to be able to partner and get out of the cold in Chicago to come down and visit you and on a clinical trial. A lot of things I thought about was thinking about how we determine care complexity based on multimorbidity. Examining pros, like patient-reported outcomes, among specific combinations of chronic conditions, and how that could actually better inform clinical decision-making. Patient engagement beyond the point of care is a lot of our work. How do you imagine, like for a diabetic patient, how much time is sufficient? Maybe not right now enough to spend 15 or 20 minutes with a patient every 3 to 6 months. How do you keep patients engaged? How do you know if something goes bump in the night before the next visit that you can actually realize, and especially now with telehealth and what we learned from the pandemic, that maybe we can set up telehealth visits more readily than we were in the past, and versus the threshold we would think about having to bring them in. So a lot of our things right now are creating opportunities through the portal, through interactive voice response and other tools, even bidirectional text messages to let patients more readily communicate with care teams. Leveraging EHRs to promote clinical decision-making and quality of care, onboarding patients into new technologies is a very big thing for us. Again, a lot of our colleagues at UT Dallas have done a lot of great work and showed even in the use of iPads that you can actually improve certain cognitive abilities through cognitive gaming. That I thought was a pretty neat advance. But then how do you actually translate that to practice? And another couple things that I think are great as Northwestern partners is we do have 2 funded NIH centers that have been long-standing. One, our Alzheimer's Center that does a lot of the work on super aging, not just on Alzheimer's, and also Phyllis C., our Center for Circadian and Sleep Medicine, who is also a partner with us in our Pepper Center, in our Center of Aging Research. So with that, again, hope that we can be considered as a colleague and collaborator in the future. We have also been launching our Pepper Center Grand Rounds that we'd love to welcome all of you to participate in. It focuses on junior faculty primarily who are Pepper scholars at other Pepper centers, and we have them do a full Grand Rounds, and it's turning into more of a national, not just a local thing. Rachel Deere, your former faculty, was our inaugural speaker, and it was a huge success. So thank you for training such a wonderful person. And again, we have visiting scholar opportunities for your faculty and students to come to us as well. It's not always cold in Chicago. So this is our center on Lake Michigan looking up. So again, thank you so much for the invitation to come out here today, and I appreciate it.
So thank you so much, Michael, for your great talk. And now it's open for questions. So if we have questions from the audience, it's welcome. And I'm not sure how we can get questions from those who are online, because I can't see the online people. Can we see the Zoom chat, maybe? Is that possible? Oh, so they can't interact? Okay. It's a what? Oh, it's a live stream. Okay, never mind. All right, so those who are online, you just listen. For those who are present, we can go around with the microphone, I guess. Can we go around with the microphone to take questions? Any questions from the audience? Yes, I see a hand up here, so yeah, you can activate your microphone. We can't hear you.
Hold it down.
I think you're good.
Okay.
I can hear you, yeah.
Okay.
Just kind of a huge question, but is your hospital looking at ways to reduce costs? Because it seems like everything it's like every decision seems to be made, a lot of them are made around the doctor, but not around the patient. So, I mean, and it all has to do with cost of, a lot of it has to do with cost of care. Results in more expense.
So probably need to repeat the questions. So go ahead.
That was a fantastic question, and a question that should be asked at every talk in healthcare is there anything going on our health system doing to address costs? And I think the question not only was addressing costs, but I think there's also issues around logistics and just being aware of what might be optimal in terms of thinking about a patient's time, a patient's distance to travel, and the questions and thoughts that a typical patient might have. I sadly think that our healthcare system, Northwestern locally, I would say we provide services just because someone thinks about it and it's a great idea. Like we have a complex care model for, kind of extracting patients that provide a lot of costs that require, they're more revolving door patients that are coming in a lot, they're getting readmitted to the hospital or to the emergency department, and taking them out of primary care and putting them into a kind of a subspecialty practice so they can be better managed. And no one even thought to think, well, how do we bill for this? And they said, well, we can just absorb it, and which is fine, but then what happens is the first bump that happens in the healthcare system, they're gonna kick it out the door because they haven't thought about it being sustained. I think there's still issues with clinical care teams not knowing, this has been going on for years, like thinking about out-of-pocket costs that a patient may experience, or even know what those out-of-pocket costs might be. It's actually some of the work of the federally qualified health centers that have been hearing, I think, what patients have been experiencing better. And so they've been creating prescribing lists, for medications that you can choose. I want to choose the medications that are attached to this formulary, or that I know that this patient can afford, or to recommend generics over brand medications, just so you're making sure that patients' out-of-pocket costs or expenses are minimized. And they've been doing this for a while. I think healthcare systems that can afford to are still wasteful, and so I think there's some really nice navigation tools that are that help, I think, with whether it be optimizing referral, thinking about what's closest to you, that I think problematically are addendums to electronic health record systems, and therefore that means it's another purchase for a healthcare system to get these things to help patients, and so they don't tend to buy them. So I think it's just still, we're in a place personally where healthcare is not optimally designed, and the fixes tend to be patches more so than a full rework. And so we hear this a lot from our primary care patients in terms of surprise costs, that they could have gone somewhere closer, that there were alternatives that just didn't come up in the conversation. So we have a long way to go. That's probably more of a pessimistic thing. I hope the wine and cheese compensate, but I think there's just a lot of people thinking about this.
Any other questions? Yes, I see a hand. Dr. Zhu.
Hi, Dr. Wolf. Great talk. So my question is related to the EHR system you have. Every year you have 6 million patients, and it seems you can analyze those massive data. Can you talk about the infrastructure you have at Northwestern for the analysis?
So the question is about the infrastructure that it takes to analyze data from more than 6 million patients that are seen every year at Northwestern.
Yeah, so we have 11 hospitals, as I mentioned, and over 200 ambulatory care sites, and we grow very fast because we've been trying to be as competitive as possible with negotiating insurance rates. Everybody's been doing this nationwide, and it's been, I think, fairly calculated in terms of which hospitals can best be onboarded, and a lot of it has been if they have an Epic platform, so the Epic electronic health record. Our health system's been pretty well seasoned with using that EHR, and a lot for research purposes. We have what's called an enterprise data warehouse, like many places. I think there's something like, the numbers are staggering, like 600 billion units collected daily or something crazy in terms of data. So there are data curation teams. So a lot of people in our bioinformatics group that are leveraging the data. And we have our center as well has what are called super users. So we do have a lot of research going on that is leveraging that team. We have a brand new Institute for Augmented Intelligence as well that is just trying to find ways to, in real time, like have a learning healthcare system. So we're actually understanding what's happening in our healthcare system and trying to be able to kind of pivot and accordingly. It's new. I would not say that we are up there yet, but it's been a great research tool in terms of identifying and targeting patients. We can turn on functionality, again, whether it be prescribing, like deep prescribing initiatives or patient educational initiatives or optimizing prescribing kind of practices, either at the level of a patient, a single patient, or we can also do it at obviously a physician level too. So a lot of our trials lately have been clinician randomized, not just clinic randomized. But I don't know if that's a one way to answer it. I mean, it's just an abundance of data that we've been able to get at. And the more we've been expanding, we just have a brand new practice in our far south side of Chicago, which is more diverse than our existing systems. That's going to further kind of help improve our capabilities, I think.
All right, it's 6 o'clock, so I think we can move now into the wine and cheese, and those who have more questions can come over. Oh, you want a question?
Out of the 6 million patients, have they done studies at your university on the amount of Medicare patients that are there? And the second part of my question is, what do you see politically? Because I know y'all are really up on a lot of the political issues with Medicare. What do you see in the future if you have your ball? Because I'm old, so I'd like to know where I'm going to be.
Okay.
I want some wine too.
Yeah, you're gonna. Yeah, I don't know how much my crystal ball is probably a little bit muddy and murky because to answer your first question, Northwestern has a very slanted, heavily private payer mix. I would say, and that's probably by design for our healthcare system. And we do have Medicare. We have. We need to do much better in the Medicare and dual Medicare and Medicaid payment in terms of the patients that we're serving. In terms of where Medicare is headed, that would be that's a question. I think I was on the radio for once and someone asked me, what is the history of cancer on a call-in show? I'm going, oh my gosh. The Medicare question, it's a really important question and one that I'm sure there are many people in this audience better than me because of how much you are tapped into Medicare data than myself. But yeah, I totally get from your perspective, you want to know what's coming ahead. And I think as things get political, I do think Medicare is less of a political football than anything else that you might see. So I feel like it's still a fairly sturdy program, but I think there's a lot of great faculty, students, and postdocs, amongst others, that are doing this much more than me. If anybody else wants to jump in.
All right, so I think we can close here the online component, thanking those who've been listening to us online. And next time we will try to make it also interactive if we can. If not, I would like to remind you that we're here in HEC at UTMB, and if you would like to come over, it's great because we now have also a wine and cheese session, which those who are online will miss. So thank you, everyone. Thank you, Dr. Wolf, for your talk, and thank you all the participants, and now we can move to the other room.